Good morning, everyone. So sorry for the delay. You know, technology is never always reliable. So we've had some issues, but we're here and you're here. And we're excited for today's topic. And we're excited definitely for today's guest. And we're excited that you were able to make time out of your lovely busy schedule to be a part. Again, this is the webinar series that we're doing on behalf of the Minority Health Partners. And we are trying to make sure that we keep in the heart and the spirit of Minority Health Month, as well as making sure that we address the concerns that partners had for what's going on in the world today. So today we are fortunate to have the Chief Medical Officer, who also happens to be my boss. I told her I was going to pump her up, so she is thebomb.com. And so please give your full attention to her. I will be co-hosting with my lovely, wonderful sidekick and friend of all, the wonderful Sunny Lou Williams, who is the CEO of TechServe and does so many wonderful things. So we're grateful for her being a Minority Health Partner. And so we hope you to sit back and enjoy the ride. And then we are going to address issues and concerns that have been given to us by partners. And then hopefully a little bit later, you'll have an opportunity in the chat option to put questions for Dr. Lindsay Weaver. So Sunny?
Thank you, Ms. Antoinette Holt. We are so excited to continue our webinar series for Minority Health Month. On the screen here, besides seeing both Antoinette and my lovely faces this morning, you'll see a screenshot of the webinar tool that you are utilizing. So just as a quick housekeeping item, want to run through a couple of items regarding your GoToWebinar tool. We have a fantastic 53 attendees this morning. We are recording live. And so for the attendees, everybody is muted at this point. If you look at your platform here on the GoToWebinar, you will have an option to take a look at chat. And if you click on the little triangle and expand, the chat function will be for you to specifically chat in any issues with audio, with any visuals this morning, and then also if there's any concerns about being able to chat in questions. On the upper portion here under questions, if you expand this portion, this will actually be the opportunity for you to post questions openly. Antoinette and I will be moderating on behalf of Dr. Weaver, and we'll be then narrating those questions to her for answering. We do not have any handouts today, so we will not be utilizing the handout section. So you'll primarily be utilizing questions and chat. Again, questions for any questions pertaining to content and any questions directly to Dr. Weaver. And then the chat functionality, which is here at the bottom. If you would like to share anything additional with the group, you'll be able to do so in questions, and you can say either share with just the organizers and panelists, or you can share with all attendees. The lovely Liz Beckner will be monitoring the chat, and also I, myself, and Antoinette will be monitoring the questions today. All right, if there are any chat items for troubleshooting or technical support, please take a look at that window and Liz will help you out there. We have more and more folks joining. We're up now to 57, so I'm excited to see everyone this morning. As Antoinette mentioned, we had a little bit of technical difficulties this morning, so unfortunately, Dr. Weaver is not going to be with us via video directly. I have a somewhat of a fuzzy picture, and I apologize, but we're going to use this as a stand-in for Dr. Weaver's otherwise lovely animated features. We're going to use her photo, and I'm just going to give you a little background over Dr. Weaver. Dr. Weaver has been with the State Health Department since February of 2020, so we certainly appreciate her coming in on such a difficult time of COVID-19 and getting sped away so quickly and up to speed on all the support that is needed within the state. She brings to the role a passion for both emergency medicine and end-of-life care. Dr. Weaver is an assistant professor of clinical emergency medicine at the Indiana University School of Medicine and practices emergency medicine at Methodist Hospital in Indianapolis. She is board certified in both emergency medicine and hospice and palliative care medicine. She earned her undergraduate degree in biology at the University of Kentucky and graduated from the University of Louisville School of Medicine. She received residency training in emergency medicine and fellowship training in hospice and palliative medicine at Indiana University School of Medicine, and she completed a fellowship in ethics at the Charles Warren Fairbanks Center for Medical Ethics at Indiana University Health. She has served as Quality Director for the Department of Emergency Medicine and Physician Lead for the System Sepsis Steering Committee at IU Health. She also served as Executive Director for the Indiana Patient Preference Coalition and as President of the Indiana chapter of the American College of Emergency Medicine Physicians. Dr. Weaver and her husband have five daughters, and we are thrilled to have Dr. Weaver, the Indiana State Department of Health Chief Medical Officer, with us this morning to discuss social determinants of health during the time of COVID-19. Dr. Weaver, thank you so much for your time and for joining us.
Thank you so much. I appreciate it. So that, I will tell you, is a very old picture. I have lots of gray hair and wrinkles, and I think even more from the past several months. Antoinette's shaking her head at me. It is true. So thank you so much for giving me the opportunity to talk to all of you. I really apologize for not being on video because I do want you just to be able to see me, but we will try our best with this. So it has been a roller coaster of a couple months here at the State Department of Health. So as mentioned, I started on February 3rd, and by the end of that week, I was giving a statewide webinar to physicians about this new virus that was happening over in China. So we just really kind of had to jump in with 2 feet and really get ramped up on educating myself on the SARS-CoV-2 virus and kind of what that would mean for the state of Indiana. So because it's a new virus, I mean, there's just so many unknowns. And I tell people that the information and the data literally changes daily. So typically with anything that I do in medicine and in science, we're very scrupulous to look over, what kind of journals we're looking at, what kind of reviews, how good is the information. And because this is new, we're relying on a lot of data points with, very few patients. So typically before we would make decisions as a physician to, use a certain medication or do a certain procedure, we'd want to see studies of hundreds or thousands of patients. But because this is happening so quickly, a lot of these studies that come out just have 20 patients or 50 patients, and some of the case reports have 6 patients on them. So we are constantly looking at those and trying to figure out what the best thing is to do, and taking the time really to learn from what others are doing across the world, as well as across the United States. So it's been really amazing to see the collaboration of scientists, medicine, politicians, entrepreneurs. I mean, really just to see everybody put their full effort into figuring out what we can do. I mean, I know that my team, I think this weekend, I was able to take 6 hours off on Easter. I worked before and after, but really kind of set my phone and my computer down and, wanted to make sure that I got to spend that quality time with my family. But other than that, we're, going on working 50 days straight, probably 12-hour days, and we're happy to do it. But it's not just us here at the State Department of Health. Like I said, we have entrepreneurs that are trying to figure out how do you 3D print face masks? How do we make N95 masks? Data companies, reaching out, how can we help you with your data to get more information? And other companies willing to donate money to help buy the personal protective equipment that we need. Talking to hospitals, how did we help prepare them to be able to take an onslaught of patients? So really there's just lots of moving activity. And we also have, speaking about reviewing data, we have an entire team of librarians and scientific experts, as well as clinical experts that are constantly reviewing the new information that comes out every single day, so that we have a team that's just dedicated on keeping us up to date and making sure that we're recommending, the best evidence-based practice. So I do give a provider webinar, physician webinar, but we have nurses on there, coroners, all different people who are, participating in healthcare right now. And I tell them, every Friday, like, this is the information for today, that things may change tomorrow. So, the CDC is constantly updating their guidance. The World Health Organization is updating their guidance. So we know that definitely can be confusing, to lay people who are at home and they're trying to keep up with all of this as much as we are. And there's news articles and there's, the governor and Dr. Box on TV every day, and the president and other people are all saying this stuff, and they're like, well, things keep on changing, and that's true, and I know that can be very unsettling to people. And I've personally had several conversations with friends and my family to help kind of walk them through all this uncertainty and like, why is there so much uncertainty? Because I think that puts a lot of distrust in people, because that's not typically, like I said, how we operate. We really typically want to take the time to make sure that we can study something very thoroughly before we come out and make any recommendation, so that we wouldn't come back, a couple of days or a week later and say, oh, just kidding, that was wrong, don't do that. But that is just kind of the nature of what is happening with this new virus, and with so many people studying it and just trying to figure things out. So thankfully, we have seen over the last week or so where we were thinking we may see us continue to spike up, that we have seen a little bit of flattening, and then in even some parts of Indiana, a tiny downtrend of COVID-19 in Indiana. So I say that, and I want to kind of break that down for everybody a little bit, that we may see the number of cases kind of go up. And that has a lot to do with our ability to test more and more. So we may get more cases, but we're constantly looking at several data points. So we're talking to hospitals, we're reviewing EMS run data. So EMS is sharing with us, so they use a term called influenza-like illness. So they kind of bracket all of their EMS runs into different brackets, whether it be trauma or like a laboring patient, and then this influenza-like illness. So somebody who has cough, cold, fever, those type of things. And so we help watch that to kind of monitor, okay, if COVID was really picking up, we'd expect to see that continue to go up as they did more EMS runs for that particular type of illness. But that's also leveled off and started to kind of come down a little bit. And then we have, I'm sure you've heard this, big dashboard called EM Resources, where all of our hospitals input their information and let us know, okay, this is how many COVID positive patients we have in our hospital. This is how many COVID patient or COVID test pending patients we have in our hospital. This is how many patients we have in our ICU without COVID, how many patients we have in our ICU with COVID, how many patients we have on a ventilator. And so we are also monitoring that. And then also in talking to our hospitals, they're telling us, that they have lots of space, that they're seeing a decrease in admissions for COVID. And they're also seeing a decrease in severity of illness. So in the beginning, when we were really starting to see this spike, a lot of people that came in were really, really sick. And we're still seeing those patients for sure, but the number of those really, really sick has kind of flattened off. So why we're happy about that and hopeful. We also just really want to be cautious because and continue to constantly monitor it, because if things would start to kind of go back up again, then we would have to kind of change our game plan. So our hope is to continue to watch these numbers, and then based on all of that, I know you've heard of the the 3 phases or guide to reopening. And I, like the rest of us, and am ready to kind of start doing some, more normal things in life. But I just want, to express that it's going to be very slow, the process of reopening, because we just want to be careful that we don't see a big resurgence, which we've heard and seen that's definitely a possibility, again, because we're constantly kind of monitoring what's happening across the world. After you open up, that you can get that resurgence. So we would expect kind of an uptick as things get opened again, and we would monitor that. And if things started to really look like they were spiking, we would have to kind of go back to the stay at home and closing of the non-essential businesses and all that again. So we might kind of as we reopen, even see where we kind of go through this whole process again. Something personally to me is that I'm a a quote unquote essential worker as well. I work in the emergency department. I actually have a shift this afternoon at 4 o'clock. So if you could see me, I'm in my scrubs right now. I wear them on Tuesdays. I feel like if I work from 8 a.m. until midnight, I get to be comfortable for the day. But I constantly am thinking about all the other people that are on the front lines. And I include that, when I stop into the grocery store to pick up a couple essential items for my family, how is that person being protected? What kind of things can be put in place? One grocery store I stopped at last week, I put a plexiglass between where the customer was and where the checkout cashier was. And I was like, that's great. That's ingenious. Like, is that 100% protect that person? No, but every little barrier that we can put in. The scrub cap that I wear to work was sewn by somebody in the community who put together a bunch of masks and scrub caps and saw that as a need and has distributed that to people. So I think that those type of homegrown initiatives of people doing what they can to help out is profoundly appreciated. I consider the nanny that I have a hero. My husband and I both work in emergency medicine, and we are very careful about showering and cleaning and not bringing the clothes that we wear into the house. It goes straight into the washing machine. I leave my shoes outside and all those things, but still we know as healthcare providers we're a little bit at risk, and so we wouldn't be able to continue to take care of these patients. I wouldn't be able to continue to do my job here at the State House if I didn't have somebody at home to help me take care of my children. So to me, she's also an essential worker. And so what can I do, as her employer to help protect her? And it's taking all of those measures that I just talked about to make sure that, if I were to get any symptoms, that I would isolate myself in my house, away from her, away from my kids, away from my husband, to just kind of help protect everybody. So we're constantly providing training to providers, to first responders. We're talking to business owners about how do you put in place things to protect people. So we know that we don't have enough personal protective equipment for everybody. I have worn the same N95 masks for the last several weeks. So thankfully, my hospital is looking into a way to actually clean masks, and the Indiana State Department of Health has also we'll be getting a big machine that helps clean masks as well. So we're still, a couple weeks away from being able to use that. But I think having the opportunity to kind of clean these masks so that we can reuse them and get them back out there is something that will be helpful, but it still doesn't solve everything, right? Because we want to make sure that it's not just healthcare workers, it's not just EMS providers, it's other people, that the dentists are going to want to start to opening up soon, the family practice doctors, and we put out a ask to them and said, hey, if you have any extra PPE, can you please, turn those into your hospital so that they can have it? And they all did. But now we're going to go look back to get them to start opening up and being able to see people in their places. How do we get that personal protective equipment back out to them? So those are just kind of the things that we're communicating about. Something that we talked to businesses about. We've spoken to several different manufacturing and factories and people in big, food services that are essential to, be able to feed all of us if they stay open. What kind of things can they do to help protect their workers and from spreading it from one another? So, unfortunately, it's closing the break room, so you don't have a bunch of people sitting in one space together. So how can you be creative and find other places for people to eat and rest where there's not 20 or 30 people into a small space? So how do you space out breaks? How do you space out people on the manufacturing line to give as much space as possible? And if it's not possible to space them out, what do we do to make sure that they have masks to help protect themselves from each other? Because I'm sure you've heard that we do know that there is some spread of disease when someone doesn't have any symptoms at all, whether it's a couple of days before they actually get sick, or they just are one of those people who never get symptoms. So we are also talking to workplaces about taking temperatures, and I always tell people that's fine, but that's just one part of it. It's really important that people, if they have symptoms, any symptoms at all, that they one, report that, and two, that they stay home. So then I talk to the businesses, that's on you, the business leaders, to communicate to your employees that you encourage them to stay home if they're ill, right? And what can you do to help support their salary and their well-being and their family during that time, right? That in the long run, it is in your best interest that these people isolate at home. As we move into this next phase of COVID-19, it really comes down to contact tracing. So when we get a positive on somebody, that we will actually reach out to them and then ask them, who all have you been around since you got symptoms and for the 2 days before you develop symptoms. And then we reach out and contact those people to say, hey, you've been in contact with this person, close contact, so within 6 feet for a prolonged period of time. You've been in contact with this person, and we need you to quarantine at home. So that's, staying at home for 14 days. That's a game changer, right? I mean, this is something that we have never done ever. And this is going to seem, it's going to be difficult. So right now, when we definitely have a lot of cases in Indiana, but as we, again, start to look to open things up, that's going to really affect a lot of people. I think the important thing to keep in mind is that that's how we can protect ourselves, is that once we start kind of, if the non-essential businesses open up and people are kind of going back to work a little bit, why it's so important that we continue to social distance, we continue to wear a mask, because if we stay away from people, then the potential of us getting that phone call, hey, you've been in close contact with this person less than 6 feet for a prolonged period of time, that won't happen because we took the time to figure out how to social distance out in our community. And then the person who becomes positive, maybe it's just their immediate family at home that has to quarantine for 14 days. The other nice thing about making those contacts with people, and something that I as an ER physician have really struggled with, is that we know a lot of people who are symptomatic, either with COVID-19 or with other things, are fearful of coming to the hospital, and then honestly are just staying at home too long. I think we did a great job of messaging like, hey, if you're not that sick, don't go to the hospital. But I think the last thing we ever wanted was the person to sit at home with chest pain for 2 days, right? Before they decided to go, or, before it was just way too far into their heart attack, and then came to the hospital. We're seeing a lot of that, honestly. And so that is my ask when I talk to people, is like, please communicate with your, with everybody that you can, that if you're sick, if you're having, that severe abdominal pain, if you're having chest pain, if you're having shortness of breath, if your legs are swelling, if it's something that is an emergency, it is still an emergency. And we want you to come to the ER to be seen, because it's a lot easier to treat something early in the process than it is several days in. And I also want to assure people that hospitals have taken tremendous precautions. I mean, literally have built, just in a couple of short weeks, rooms specific for COVID-19 patients in areas, and they have plans, and they do not want to get anybody else sick. And so they, are making sure to deep clean any room that people have been in, and taking all precautions. And so, while there, if you go there, there's probably COVID-19 people around, that absolutely people will be protected to the absolute, best of our ability, and we want to be able to take care of you. So I think that we are, from our standpoint, the State Department of Health are trying to communicate that better to people to seek that care. But I think that, it really comes down to getting out into the community, that message that we're still here for you. The doors are open. We want to see you. Please use, telehealth when appropriate, but if you get chest pain in the middle of the night, that's the time to come in. I know there was a lot of questions about the data flow, um, and kind of, we're like slowly improving our dashboard every week. And a lot of that is just, again, this is something that's totally new. So typically with diseases, providers only had to report on positives. And so like at the, the start of this, that was what the expectation was. So some labs always were just kind of importing all their data. So we saw positives and negatives, but a lot were just kind of sending in positives. And so we, Dr. Box put out the executive order, hey, we need to know your negatives too, because we need to know what the denominator is. How many people are we actually testing, which will give us better information on the number of positives. Additionally, as you've heard, we have a kind of a limit or a resource supply chain issue with getting the swabs. And so we know that especially in the beginning, we are really focusing on reserving those swabs to test our people that are getting admitted to the hospital, our nursing home patients and staff, our healthcare workers, our first responders, and that got expanded to essential workers, got expanded to people who are most at risk. So people over the age of 65, people with diabetes, hypertension, obesity, pregnant women, and we're expanding that, even more. As we get more supplies, we're continuing to open up and expand. And so with each layer of that, it's, making sure that we're connecting with the hospitals or the local health department or whoever is collecting the information on those patients. And so that's some of kind of the delay in getting information out about age and race and ethnicity and even county, because in the beginning, there were some people who were, testing a bunch of people and weren't even collecting phone numbers on those people. They just had a name and a date of birth. So when my epidemiologist, the State Department of Health's epidemiologist, went to try and figure out more information on these people, that's all they had to work with. So as we're kind of getting in the flow of all this and realizing, this is the information we need, when more people come online, we let them know, hey, these are all the things that we need you to collect from people. All these data points, including a phone number, an address, and et cetera, so that if they are positive, that gives us the opportunity to reach out to that person and start doing that contact tracing when we're ready to get there. We're talking to, several companies and, again, I mentioned entrepreneurs and just super inventive people. It's just crazy to me how quickly people are able to get things up and going. About what does contact tracing mean, how much of it we can get automated. I'm sure you have heard about that there's kind of an opt-in process. I think Apple has it where you opt in to, just by GPS, so that if you've been in close contact with someone who's been identified as COVID positive, that you would kind of get an alert, hey, you've, been in contact. Or how do we use, data and the fact that most of us have a cell phone on us at some time to help us with that contact tracing, as you can only imagine how many people, I think, so we know Massachusetts said they had to hire 1,000 people to help do the contact tracing. So where can we use data to help us with that? We are, watching the states around us and across the country. I think everybody's done most of the same things, but there's definitely been some varying approaches. So we're looking at their dashboards. Dr. Box has a phone call with all the state health commissioners once a week, and that's been a super informative phone call. In the beginning, when Washington was having their outbreak in their nursing homes, that's really where we got the idea that we needed to get on top of it and started doing and developed from the very beginning, a task force that it was dedicated just to nursing homes and strike teams that were able to deploy out to nursing homes to test people. So recognizing, in talking to the state health commissioner in Washington, that this, clearly this was going to be a focus and likely a problem. And I think that we've seen that across the entire United States, where our long-term care facility nursing home patients are really, really at risk. Additionally, Dr. Box and I, have had phone calls with hospitals and in long-term care facilities to start to think creatively about how they can help improve communication between families and patients in hospitals and residents in nursing homes, and to think about, like when it's possible and everything lines up well, could we allow, one visitor to visit somebody in an end of life situation that kind of originally everybody, said no visitors. We needed to protect the visitors. We needed to protect the patients. We needed to protect the healthcare workers. But, Dr. Box and I both strongly feel that it's really important that we still, recognize who we are as humans and our needs, and that how important it is, not only to the dying patient, but to the family to be able to be there and hold hands, even if it's with gloves, and look somebody in the eye, even if, when you're wearing a mask, and be able to spend some time with someone. Now, again, our primary, goal with all of this is to protect people. And so that's something that, each hospital and nursing home will have to figure out how they can best protect the visitor, protect the patient, protect the healthcare workers. But just to kind of think about, knowing that this isn't going away, we're going to be at this for a while, just thinking about different ways that we can still be humans and have that human connection, and just how can we kind of make things work. I know I've covered a lot of things. I didn't know if maybe we could open it up to questions at this point. Would that be okay?
Absolutely, Dr. Weaver. Thank you so much for a fantastic overview and summary of detailed information pertaining to the COVID-19 current symptoms and overall impacts and data within the community. Coming back to social determinants of health, I'm going to weave some of the questions that have been asked by our attendees back into the social determinants of health details here. As we all know, social determinants of health from an education standpoint is incredibly important that we have good literacy on any of the topics that we're talking about. So specifically literacy on COVID-19, we're going to direct some of the questions here. In terms of possible exposure to COVID-19, what length of time is considered prolonged to be around someone who has exhibited symptoms or tested positive?
Yeah, so that's a great question. Oh, sorry. And something that, again, is kind of constantly changing. So, and it depends, were you wearing a mask? Was the person coughing? Those kind of things. So I think what most people are using within that 6 feet and greater than 10 minutes. So in the beginning, they were saying greater than 1 minute. But I think that, again, like I said, it depends. If both people are wearing a mask, I think that your exposure risk is definitely lower. So like, for example, in the hospital, even if I'm around somebody that has COVID, and I know they, find out they do have COVID, if they were wearing a mask and I'm wearing a mask, we don't consider that an exposure. So that's, another reason why we're encouraging to start people wearing masks out in the community. And again, like if that person is coughing and you're getting, and that's at 6 feet, I just want to kind of explain that too. Everyone, asks like, where does that 6 feet come from? And that's what it is. Like, how far, when you cough or sneeze, do droplets travel? And we, based on most recent data, we do believe this to be what we would call like a heavy virus. So it does drop in the droplets. But that the extent that it would go if someone were to cough would be about 6 feet. And that's based on data that we've had on other kind of droplet viruses in the past. I also wanted to add that people will hear a lot about aerosolizing procedures. And that's really something that only occurs with healthcare workers. So that would be like someone who's getting a breathing treatment, or when I would have to, intubate someone and, use the bag to help them breathe. Or like, if we're doing work in somebody's mouth and we're using a drill or suctioning. So those types of things. So with the exception of breathing treatments, which definitely happen in people's homes, most of those aerosolizing things where you have to wear that N95 mask, that mask that fits really closely to your face, aren't necessary. And that regular masks do just as well to help protect you from that kind of like 6 feet if you're in that close contact.
So I want to repeat that just to make sure that everyone on the on the attendees list here today has that information, and also for folks that are recording, because I know we're also hoping to debunk a lot of myths out there. The first thing is stay 6 feet or more apart. And secondly is wearing just any type of mask to prevent your own sneezes, bodily fluids, et cetera, from traveling is the two most important safety factors at this point. Then anything else in addition to that would really be looking at circumstantial. Is that a correct summary, Dr. Weaver?
Yes, that's correct. Most of the time it's really like your people who live in the home with you is the people that are getting sick, or if you like have to work side by side by somebody at a place. We have had some facilities where several of the workers got sick, and we really do believe that happened by everybody using the same phone, using the same computer, not washing their hands in between, or maybe sitting at the same table or workbench. So those are the kind of things that we're going to have to think differently about and do differently as we start to open up businesses.
Great, thank you, Dr. Weaver. Along those lines, for the community's impact, could you talk about the testing process and how testing is actually conducted and how long the wait period is to receive test results? We know we've gotten lots of questions and lots of concerns about how it's actually done operationally, when it's going to be available, and so forth.
So there's the primary test that we do is actually a swab. The labs that we work closely with prefer what we call a nasopharyngeal swab. And that swab actually goes back pretty far back into your nose. So honestly, where it kind of reaches the back of your throat. So people will feel kind of a little bit of scratching in the back of their throat. It's swished around in there. The goal is to get as much snot on it, honestly, so that we can get as much virus on that swab. Some people also do what we call an oral pharyngeal swab. And so that's a swab of the back of your throat. People probably have done that before if they were possibly getting tested for strep. So that is what our primary test is. There are some people that are doing a swab just at the front of your nose, what we would call an anterior nasal swab. So just kind of right there at the opening. The worry about doing those is that you could possibly not get enough of the virus on that swab. So the labs are in the process of testing that process, and there are some companies that are running those tests right now. So I think that's something important to know too, is that, depending on who performs it and where you're at, there might be a little bit of a different process. And that just kind of, comes down to what kind of swab is it, because certain swabs are the ones that go to the back of your nose. Different kind of swabs is what you use to swab your throat. And then there's a different one to swab the front of the nose. And then depending on the lab and the tests they run, whether or not they accept different swabs. And then additionally, different companies have different what we call turnaround times. So how long you're going to get those results back. So we have received some machines from the federal government that is able to actually do the testing within 10 to 30 minutes. So it's a super quick test. But because it's new and these went out across the entire United States, even though we got 15 machines, we really didn't get enough testing kits, the actual kit, to test a ton of people. But we're hoping to continue to get those over the coming weeks to get those kind of quick tests out there. The vast majority of testing, those nasopharyngeal swabs that I was talking about and the oral pharyngeal swab I was talking about, those can take anywhere from 24 to 48 hours to up to a week, depending on where that test is sent. So people who are hospitalized, healthcare workers, we really want to make sure that we can get that information back quickly because it really might change how that patient's taken care of, and of course, what to do with that healthcare worker. So those are definitely quicker. But if you were to go to, for example, a drive-through to get tested, it's probably going to be longer to get those results back. depending on where you get tested will also change how you get contacted. So for example, if you did like the Lilly drive-through, I know they actually have a portal where you can go in to get your test results. So one of our local health departments is putting on a drive-through testing, and they call people back. The State Department of Health has put on several drive-throughs all across the state of Indiana, and we call people back. I think that, and it depends on, you might get called back from the State Department of Health, you might get called back from a local health department. So that whole process looks different for everybody. There's another type of testing that is coming out, and it's called antibody testing, and that's actually a blood test. So depending on the test, again, it's different, whether it's a prick of the finger or actually a small blood draw, and then the blood is tested for antibodies. So typically with viruses that we have had the opportunity to study for a really long time, when we check for antibodies, we can say, okay, you've had this virus and your body has built up antibodies to it. So you are what we would call immune. So you aren't spreading it anymore and you can't get it anymore, whether that be for a week, couple months, or a year, depending on the virus, because all virus, or lifetime, all viruses are different. The problem being, as I mentioned in the beginning of my talk, is that we're just so early in trying to figure this all out, that even though we have the ability to test for antibodies and that the tests are being developed and made and are out there, we don't know what to do with the results yet. So if I got tested today and it came back positive, and they said you do have antibodies, that doesn't honestly even mean anything. It doesn't tell me that I am okay to walk around without a mask anymore. It doesn't tell me that I couldn't still be spreading the disease if I had had it. It doesn't tell me that I'm going to be immune, so I can't pick it up again for weeks or months or years. We just don't know. So we're in the process of studying all that. We are going to start doing the antibody test so we can start collecting that data as we figure it out. And then if we get some better answers, the opportunity would be to call people back and tell them, okay, you did have these antibodies as we had told you. Now that we know more information, this is what it actually means. So, clearly we're not going to be able to know if you're immune for, months or years, because this has only been around for a couple of months, but at least we'll be able to tell people that, this means you're immune for at least a month or whatever, which I think would be a nice thing to know if we can figure those things out. But I do appreciate the opportunity to kind of talk through that, because I think that we'll be hearing more and more about these antibody tests, and I just like the opportunity to explain to people that it's, while it's great to not get too excited until we actually know what those results mean. Additionally, unfortunately, some of these tests, if you have had a cold, so a different coronavirus, it could turn this test positive. So we're doing more tests so that we can know for sure if it shows that you have antibodies, that those antibodies are actually to this COVID-19 and to not one of the common colds. So there's just all these things that are kind of up in the air that we're trying to figure out.
That's fantastic, Dr. Weaver. With the discussion on the antibody testing, there was a flurry of questions from the attendees regarding how to seek out an antibody test. Could you just repeat again your recommendations at this point regarding the newness of the antibody testing?
Yeah. So my recommendation is, I don't want to discourage people from getting tested if it's offered to them. I just want people to know that unfortunately it just doesn't really mean anything to us yet. That we wouldn't be able to give any recommendations based on the results of it, because we just don't know how good the tests are, and two, what it actually means for how immune you are to the virus if it were to show you have antibodies. So what happens in an emergency is that all of these different tests are allowed to be put out in the market while the FDA is figuring out whether or not it's good. So there is lots of tests out there that have not been approved by the FDA. Now they're approved to be out there because it's called an emergency use. So we know that we're in a pandemic. We want people to get stuff out on the market as fast as possible, as long as it doesn't cause harm to anybody. And so all these companies are putting out these tests, but there's only, I think there, as of this morning, 3 or 4 tests that have actually been validated and approved by the FDA. So I know that there are tests here in the state of Indiana where we that have not been validated and approved by the FDA. Now, does that mean it's bad? No, not necessarily, but it's just to kind of explain that there are these different tests and they're going through the process of validating. So I would just ask a lot of questions. You know, if you were to get this blood test at a primary care doctor or whatever, you know, is this test, has it been approved by the, or validated by the FDA? You know, when can I expect to get my results back? If they have better information on these antibody tests in the future, will you call me back and let me know what those are? Those are the kind of things that I would want to know. And we have put together a kind of a frequently asked question thing about antibodies that we have provided to our doctors and our hospitals. And we're working on something similar that we can provide to, you know, to Hoosiers, so to lay people, so that they can try to you know, make informed decisions and just kind of know a little bit more about where we're at in the process with antibody testing. So that's something that's in the works.
Fantastic. Thank you, Dr. Weaver. Along with the social determinants of health on the education side, because literacy is so important and literacy on the disease state is so important, the information that you've provided us regarding what we should be doing now, physical distancing, ensuring that we're wearing the appropriate, that we're utilizing the appropriate physical and social distancing practices, accounting for better understanding what testing today that's available looks like, what questions we should be asking and what we should be setting as expectations for turnaround time is just phenomenally important. We're going to gear the next segment of questions towards best practices among groups. We have many minority health partners here that are leadership of clinics, of nonprofit organizations, of community service provider organizations, et cetera, where they're today already working within the community, still continuing as essential workers to continue to function within their in jobs and continuing to support their organizations and the community with the good work that they're doing. So a couple of questions along those lines. Regarding sharing use of equipment in the office, would it be appropriate to have staff use an antibiotic wipe after each use to clean copiers, fax machines, and other shared equipment? What are your recommendations on appropriate sanitation within the office workplace?
Yes, absolutely. So when able, and this is something that we do at work, we didn't, but now this is something we do now, is to have, this is my assigned phone. This is my assigned computer for the day. If it's something like a copier where that you have to, you know, several people are going to be using it during the day, absolutely use an alcohol wipe or one of those antibacterial, antiviral wipes to wipe down the parts that you touch. And that also includes doorknobs, maybe, you know, the coffee machine is a very popular place at both the places I work. So make sure that you're wiping down the handle. And I think just being conscious of it, you know, we unfortunately have not had to, you know, be super worried about these things in the past, even though we've always said, wash your hands, clean surfaces, but now is the time to just really to pay particular attention. I think one of the recommendations that's going to come out is that, you know, have a infection prevention, you know, leader at your place of work, somebody who is going to read the material, watch the video. We're going to put together a bunch of stuff when we start thinking about reopening for businesses, who is, you know, takes the time to really kind of learn those things and then takes that back to your place of work to spread those best practices and come up with, okay, this is what this means for our company. You know, we are our place. We only have one phone, so we don't have the opportunity to assign a phone to everybody during a particular, you know, shift or time. So this is what our standard of practice is going to be for using the phone. After you use the phone, you it's your job to wipe it down. We're going to put a little thing of wipes right next to it, or what, whatever it may be. So I think that's, that not that you have to have a separate person or hire someone separately, but that just someone really takes charge of making sure that that person is staying up to date with the recommendations.
Dr. Weaver, I have a real quick question before we move off of that topic. Because there's such a shortage and high demand of cleaning wipes and different things and people can't find it, could they use an alternative like a bleach water solution and paper towel to wipe down their stuff? Would that be okay? Or is there another recommendation that you have in regards to that?
No, that would absolutely be okay. And I think that there are recommended recipes for that. So I think that's something that maybe we could work on to get together to be able to provide to people. I even know of a hospital who started making their own cleaning solution and hand sanitizer based on the material they have. So I'm really hopeful that now that we're several weeks, months into this, that our supply chain will be able to start to kind of pick back up and, fill in a little bit. And so things will become more available with each coming week. But absolutely, I think in the meantime, doing those kind of things, as long as you're careful, please. I've taken care of plenty of people that have had splashes of bleach in their eye and everything, that's appropriate.
Great. We've heard a lot about personal protective equipment. PPE has now become a known word. That is a understood acronym amongst even laypersons that were not originally part of the healthcare systems. What are recommendations that you have for personal protective equipment? Perhaps not in the true definition of PPE, but what should we as individuals that are not in the healthcare system, as day-to-day individuals going to work or going to grocery shop, et cetera, what should we have on hand?
So really it's the mask. So we do not recommend that people wear gloves because you're just kind of moving unless you've been trained on the proper use of gloves, which we are in healthcare about, when I put my gloves on, I only touch this and then I take them off immediately and then throw them away, that you don't kind of move from thing to thing, that it actually can make things worse. So we don't recommend gloves. I would recommend that people have on them a little thing of hand sanitizer, which again, I know is in very short supply right now, but that's what I would go to the grocery store with, and just, walking around daily life is I wear I wish you could see me right now because I have it with me, but I have a super cute little Shopkins mask that was, like I said, made from someone in the community with me. So I wear my mask and then I have my little thing of hand sanitizer. And I also put a bunch of alcohol wipes in my bag that I use to clean my phone several times a day. So our phones are very, very dirty. So those are the kind of precautions that I take out in the community and recommend to others. So in the hospital, we wear goggles, and then of course gowns, but we're doing things where we have the potential of getting splashed on, right? Whether it be, I won't even, you can imagine all the different liquids we get exposed to. I won't say them out loud for you, but so that's why the goggles are important to us, and the gowns, and of course, I think the most important thing, the thing that we can really do for each other, is that we protect the rest of the world from ourselves. So if you're coughing and sneezing, stay home. But if you're out and you have allergies, like most of us, and you have to sneeze, then please, be wearing that mask or cover your sneeze, so that you don't, kind of spray somebody else, just to protect everybody else that's around you.
That's great. And just to summarize again, hand sanitizer, alcohol wipes, and your mask. And those are your own quote unquote consumer-based PPE to go out.
Yes, exactly.
Then when speaking of exposure specifically to healthcare workers, we have an attendee that chatted in the question of, is it true that it is due to not having PPE as the main reason to why many healthcare workers have gotten COVID-19?
So we we have been able to fulfill most every request for personal protective equipment across the state of Indiana. And it is not ideal. For example, like I said, me wearing my same N95 for several weeks on shifts. I put it in my little paper bag. That is not the ideal way to use that. They are meant to be thrown away actually after each patient use. So could it be a little bit of that? Absolutely, I can't say that. What I will say is that, in the hospital, we're in communal settings, right? Where we're around each other, we're touching surfaces, that it is so this is the way it was explained to me, and I think this is a great explanation. If you are, constantly being exposed, 20 times over the course of an, 12-hour shift, then your likelihood of something in there, picking up the virus and all those different things is way more likely than someone who, goes to the grocery store and maybe passes 10 people, but you're not standing there in front of them for a prolonged period of time, and things are, it's just kind of a different atmosphere. So just the way that we work makes us more at risk. I'm not going to sit here and say that the personal protective equipment is wonderful out there, but I don't think that that is the only reason why healthcare workers are getting sick. I mean, it is the whole process of what we call donning and doffing. So putting on all of our personal protective equipment and then taking it off is a very kind of detailed. You have to really be paying attention to what you're doing. And so in the past, I might do that one time a shift, but now I'm doing it, 10, 15, 20, 30 times, the likelihood of kind of making mistakes in there also definitely occurs. So things are not ideal, which adds to everything, but just the simple nature that we're constantly being exposed to it, and that it's everywhere, does increase our risk. And the fact that we're just out in the community, right? So we don't stay home, that we're out and about and we're around other people.
Well, thank you for that, Dr. Weaver. We certainly covered a tremendous amount when looking at the social determinants of health in the neighborhood and physical environment context. Starting from us specifically, what should we be carrying as our own quote unquote consumer-based PPE, what we're looking at as the environment of our offices, workplaces, and the places that we have to have social interaction in, specifically because we are essential workers or because we still have community outreach and engagement and support services to conduct. As we transition over to the next social determinants of health area, we're going to be looking at community and social context. So the social integration, the support systems, community engagement, discrimination, stress, and so forth. Specifically for those on the call today, minority health partners, we've heard a lot on overall myths with pertaining to the minority community about how COVID-19 is transferred. And you've done a great job providing us the real accurate information on just the general education and literacy on the disease. Specifically to minorities, we know that from a social determinants of health, there's a much greater health disparity. And so that, of course, impacts even more significantly when we have something like COVID-19, where there's a barrage of information, where there's an unknown as far as being able to navigate the supply chain of vendors, testers, and actual access to this testing and so forth. When you look at the minority population as a whole, what do you think or see specifically within either central Indiana or statewide as specific areas of concern pertaining to minority-based access or minority-based impact from COVID-19?
So we definitely have seen where that our minorities have been disproportionately affected. So, with just looking at positives and death rate as well. So it is something that we unfortunately we're expecting, just knowing the numbers of like chronic illnesses that make people more susceptible to COVID-19 for a lot of reasons that we haven't quite even figured out. So specifically, diabetes, hypertension, lung disease. So that's asthma and chronic pulmonary obstructive pulmonary disease, so COPD, and then obesity with a BMI greater than 40. So we knew based on the information we were getting before COVID-19 even got really around the entire state of Indiana, that those were really big risk factors. And so we are worried about it. I've really appreciated all the work that Antoinette has done to talk to community partners about education. How do we reach everybody with education on how to, like exactly the things we're talking about here today. How do we protect ourselves? How do we protect each other? And a reminder of, you're at risk. And so because you're at risk, you need to protect yourself, but also me as your friends and your family, I want to protect you too. So what does that look like? My parents are both at risk based on age, and also my dad meets all of those at-risk categories. And so, us as a family, and then my community as well, we said, as much as we want to see you, Dad, and interact like we normally do, we're not going to, right? So we're going to stand on the sidewalk, and we're going to talk to you that way. We're going to call you. My sister-in-law drops off food at their house, and then my mom and dad then taken in that way, and there's very minimal interaction with things. And when they take their walks around the community, they make sure they protect themselves and they stay away from people as they're passing on the sidewalk. So I think it's just making sure and acknowledging the different ways that communication is received and that education is received, and then how can we start to help suggest and also give people the opportunity to develop their own ways of doing things differently, right? Like I always say, like I believe in my community to figure out what does this look like differently, whether it be my church did a video of Easter Mass that we sat there and watched on my computer at home, and I know that other churches kind of did a parking lot thing where everyone stayed in their car. So what do other celebrations look like in the future, that we still want to be able to celebrate and connect and kind of get that education out there to the community to be creative, and this is what you have to worry about, and these are the people you have to worry about. So what can we do to really protect them, and also how can they protect themselves? Antoinette, I don't know if you had anything else to add to that.
I think you covered most. I mean, we're grateful for the opportunity that, our state, not so much just necessarily unique, but it's taking a value interest in making sure that we're inclusive of everyone. And so their efforts in regards to what they're doing, they're making sure that we are reaching our most vulnerable populations and making sure that we are doing things that address the needs and concerns, just like today, answering questions and things so people can be empowered to make informed decisions that they need for their organization or their communities and different things. So we're going to continue seeking you, our minority health partners, or even those that have joined us today, in regards to insight as far as what are the needs and concerns in your community, because we can't be everywhere in every place, especially now with COVID-19 restrictions. So we're definitely depending upon the things that you hear and you see that will help us to be able to address that and be able to make sure that we are addressing all Hoosiers alike. Internally, we're working internally with our agency and departments. We've talked to Dr. Weaver about making a mitigation resilience report, which would kind of just highlight specific needs and concerns as far as Indiana and vulnerable populations. So there's a lot of different things that we have in the pipe. We're making sure we're trying to gather intel so we can put on our website resources that you can go to for our partners and things, but if you maybe need a different language or you need to know who in your area is doing what, these are things that you'll be able to utilize. And so, again, we want to make sure everything is accessible. We want to make sure that we are addressing the concerns and needs of everyone. So I think you, Dr. Weaver, hit it right on the point. Okay.
Fantastic. Great. Then we have one last question, Dr. Weaver. I know we've got so many questions today. We want to be conservative of your time. I know we were a few minutes over your availability. One last question regarding the support for minority populations. You've already discussed so many great strategies, so many great tactics for social distancing and also carrying our own PPE and how we account for our workspaces. What is your opinion about the opportunity to allow for minorities to have a more directed and more prioritized access to testing?
So what's our plan for, just repeat the question for me, sorry.
Sure. What is your opinion on giving minorities prioritize access to testing given the health disparities that are experienced?
Okay, yes, absolutely. So that is something that we have actually been working on significantly over the past couple of weeks. So we, wanted to bring testing. So because it really depends on where do you live, where do you work, live, and play, and how accessible is testing. So we have set up testing sites in communities. Where we recognize that there was a inability or a lack of access to testing, and we continue to do that. We're going to be doing a significant amount of testing over the coming weeks. At the same time, trying to transition to how do we get the testing back into the hands of the people who typically would do these things. So for instance, some of those rapid test machines I was talking about have gone out to community clinics across the state that serve underserved populations, because we wanted to get that quick test out to them so that they can quickly give somebody the results back, so they wouldn't have to wait for a phone call or some other kind of way to talk about it. And if someone is an essential worker, they can get that information communicated to them relatively quickly. So we are talking to our providers in the community, our local health departments, who feels comfortable to start to kind of take on this, because we can't be everywhere, kind of like what Antoinette said, we can't be everywhere. So we really want to get this back out into the hands of the people who typically would provide these kind of services. So of course we will have to significantly increase our supply chain, have more swabs, make sure that our labs have the capacity to do the testing. So those are all kind of the moving pieces that are going on right now.
Would you be comfortable, Dr. Weaver, to talk a little bit about what some of those organizations would look like, what they could do, what kind of training they could potentially onboard to be one of those local community testers?
So yeah, we wouldn't expect that. So we couldn't get every place kind of everywhere up and going all at the same time. So what we're going to do is we're going to kind of map out the state, know where testing is already provided, and look to see where the gaps are, and then how do we get into the communities that would have more difficulty accessing those tests and prioritize them. And absolutely, because our drive-throughs have been running for a couple of weeks, and we also have the strike teams that get into nursing homes, they have a protocol, include pictures and everything about how do you collect the test, how do you screw the top on. I mean, it's super detailed that we would then be able to provide to people, when we get to that point where we're ready to kind of move to that next step. So that's exactly what we'll do. We'll help identify people, make the connection. Are you willing? Do you have the people? And then what can we do to help make sure that you have the materials? So like the swab kits to do it, the education on how to collect it, the education on how to communicate those results, and then also the PPE to do those collections. You have what you need to protect yourself if you're actually going to be testing people. So that's kind of that's a sneak preview into next steps. But in the meantime, ISCH is going to continue to go out into the community to provide that testing as we work on getting everybody kind of back up on their feet.
That is phenomenal. Thank you, Dr. Weaver. Any additional questions from the audience before we adjourn for today? I know we have a phenomenal resource in Dr. Weaver, but I know she has to head back to the myriad of roles that she's playing, both in the ER as leading our state response efforts, oversight of our minority health overall increases within the state. So we certainly would love to keep her longer, but know that that time is very, very valuable. Any additional questions that we can help to answer and respond for today? Oh, I think we have one last question here, which is an interesting one. Dr. Weaver, you mentioned earlier about the enormous amount of data that we're capturing and collecting across EMS, the state health agencies, local departments, of course, these drive-through clinics, et cetera. How are we keeping the data security along the lines of this information being collected? How are we keeping that safe? Can you talk a little bit about how the data capture is being done from drive-through to some more intensive collecting?
Yeah, yep. So the majority of it is our typical avenues of using the electronic medical records that are already out there for hospitals, and they, already most of these kind of data reporting places were there for people to report other kind of diseases that needed to be reported. Hepatitis A, hepatitis C, those kind of things. So that whole process, and it's all HIPAA compliant, was already established. So people who have come on and started doing testing that maybe didn't have those HIPAA connections, that they have to get an agreement, an understanding of all the complexities of HIPAA so that all that information is protected. And that only kind of the right people get it. So like the EMS data, for example, it's completely, unidentified. It basically is just a number. This is how many runs we've had in this area over the last week. The information from the hospitals is, again, them just sharing us a graph to us of this is how many people we have admitted to the hospital with COVID-19. And then, like I said, because it's a reportable disease, we do have that, next layer of information on all the patients who have been tested and who have been tested positive. And that's all, kept very closely and only to the people who need to know it to do that contact tracing and that follow-up and those kind of things. So most of the stuff, like I said, has already been established, and we're just working within those already established kind of data transfers.
That's wonderful, and thank you for that. There were a couple additional questions that were resource driven. So I wanted to point everyone again back to the ISDH coronavirus update website that Antoinette has been sharing with us through each subsequent webinar. So please look to that. There were a couple of questions regarding social determinants of health equity plans across the state. We also at the Indiana State Department of Health, there's a state health assessment and state health improvement plan that addresses social determinants of health and health equity. So please also refer to that document. We'll also send that out to everyone at the close of this webinar as well. Dr. Weaver, thank you so much for your time in addressing social determinants of health with us today. It has been a pleasure. Thank you for taking so many rapid fire questions, for dealing with the technical difficulties and not being just able to show your video, for your wealth of knowledge and your continued support, leadership, and response on the front lines. I greatly, greatly appreciate it. Antoinette, back to you, ma'am.
Thank you very much. I was trying to answer a question. People were texting me on the side. So I want to thank Dr. Weaver again. Thank you so much. You did a Herculean job. I appreciate it. I know that you are running like a chicken cut off about the head. And so in this time, we appreciate you taking time out for that. And thank you, everyone, for joining us today. That took time out of your schedule. I had put a picture to a friend showing how COVID working now. And so I got 2 laptops going and everything down. So I know the phone and everything. So what used to be a dining room table is now your workspace / whatever. So we thank you for, again, making that. Any questions that we didn't get a chance to get to today, we'll make sure that we will address those amongst our partners and then even with our e-staff when we talk to them again. We definitely want you to please go to coronavirus website that we provided, coronavirus.in.gov, to get updates as far as the numbers. The numbers come out every day after 10 a.m. and they'll have a breakdown in regards to demographics below. And we're always continuing to see what we can do specifically to change or update and give more information. So please be patient with the state as we continue in the process of doing things. Because like I mentioned before, what used to be weeks on weeks that would be a process of getting you data is now being turned over 24 hours and 24-hour time span. So some of the data would change, percentage as far as how minorities are affected or African Americans have changed a little bit as far as the numbers. And so continue to just be abrupt, continue to be vigilant in advocating for your communities and target populations. Please get involved on the local effort. There's a lot of things I know that's going on in Marion County or Lake County and different things that people are trying to do to address coronavirus, especially when it's dealing with vulnerable populations. So I encourage you to get on board if you're not already on board. And then if you always have any questions, I'm sorry because they're mowing the yard outside. So if you have any questions, please feel free to email me. I check my email constantly, even in odd hours. Don't ask me questions. And then also I want to give thanks to Sunny Lou for not only just co-hosting, Sunny Lou Williams, I'm just calling her Sunny. So I want to thank her for co-hosting. I want to thank Techstar for providing the vehicle for us to be able to do these webinars. I want to thank our sponsors. I want to thank definitely IU School Social Work. Davina out there, appreciate all your hard work and diligence. Thank my staff. Thank you. I think that's it. If you have any other questions, we'll see you next week at the same time, same place. We'll be talking about crisis management and coronavirus, and it's going to be on a different level next week. We'll have all our state offices of minority health from around the nation and minority health entities. So it'll be a good opportunity to process because it will allow us as state offices to let you know what's going good, bad, and indifferent. And then you get to kind of see that, there's more than just me, Antoinette, that exists as far as minority health, that you have all these other men and women that are working hard and diligent for their states too. And since we're especially on the effort of regionally trying to chime in together to work to address this issue, I think this would be a great opportunity for you to listen in on the session. So it may be a little set up differently next week in regards to participation, but you being there is going to make the difference. So again, thank you so much for joining us. I don't have anything else to say. Do you have anything else to say, Sonny? All right, we're good to go. Be safe. Make sure that you're washing your hands, have hand sanitizer on you, get your face mask. Ask your local church person, ask your local community person. If you need one, I know somebody that's selling them, or we'll connect you to somewhere. Make sure that you're protected. Make sure that you're staying safe. Let's love one another and stay home. Stay home. I know it's hard. I know some people are ready to go cuckoo for cocos. Don't do it yet. Stay home. Be encouraged. Know that it's going to be okay. And we're going to survive this together. But working together works so much. And if we just care for one another, do it for yourself. Do it for your family. Do it for our frontline workers like Dr. Weaver and people that are going constantly, they're exposing themselves and chancing just to take care of us. So the least that we can do is stay home. All right. That's it. I've done talked enough. Have a good day. Have a good week. See you next week. Bye-bye.